Good afternoon, everyone, or for most of you guys, good evening. I would like to welcome all of you to the Society of Skeletal Radiology Educational Club, Resident Educational Club. My name is Kamiz Monameri. I work at UCLA, and I will be serving as the moderator for this session. And it is my greatest pleasure to introduce the speaker to you. It's going to be Dr. Hank Schilling from University of Utah. He's an assistant professor and the co-director of the MSK Fellowship, and he'll be talking about musculoskeletal interventions. Hank, please take over.
Right. Thank you, Camis. So yeah, I'm Hank with the University of Utah, and super excited to be kicking off the REC lecture series this year. As was mentioned, I'm going to be talking about MSK procedures, and the idea is to summarize kind of the oral tradition of musculoskeletal training in order to maximize success. So I have no disclosures, but I do want to acknowledge my colleagues who contributed their knowledge and cases and material to this lecture. So what's the purpose of this lecture? The idea is that a lot of what makes you good at procedures, that knowledge and ability, doesn't come from reading books or articles or watching video tutorials, as those generally focus really on the kind of basic technical fundamentals of a procedure. It comes from doing a lot of procedures, and it comes from having good teachers who can share their experience and their kind of wisdom, tips, tricks, and pearls with you. And so this really reflects a largely oral tradition of medical training, and things that are largely unwritten. And so the goal here is to try to summarize a lot of this information that's kind of floating around our team here at Utah and present it in a way to you, and hopefully some of that material is helpful. Obviously, by its nature, a lot of this tends to be more anecdotal or kind of experience based, but I do try to provide an evidence basis wherever possible. All right, so we're going to divide this between before, during, after the procedure, and then some brief CT-specific considerations. So starting with how to deal with allergies. So lidocaine, of course, we use for basically all of our procedures. Most local anesthetic allergies are actually, adverse reactions, I should say, are actually non-allergic and rapid onset. True hypersensitive reactions are thankfully rare. So what do you do if somebody has a reported severe allergy? The most conservative route would be, and especially if this seems like a true allergy, it would be to refer them to an allergist or a dermatologist and help figure out a plan for how they're going to deal with this, as it's probably going to come up many times over their life. I think in reality, we often don't have a great history about exactly what an allergy is, and patients may not want to go through this whole process. If it's a more urgent procedure, you have a couple options. So one would be to switch groups. So most of the local anesthetics we use are these amide groups that have two I's in them. So bupivacaine, lidocaine, ropivacaine. So you can switch over to these ester groups like benzocaine, procaine, tetracaine. Don't recommend use cocaine, but so there is some cross-reactivity between these two groups. However, it's less likely to have a severe reaction. Another thing that we've had success with is instead of a local anesthetic or instead of one of these, you use 1% diphenhydramine as a local anesthetic. And this has good local anesthetic properties. It actually works quite well. It has a shorter duration, so you may need to reapply, but this has gone through some what otherwise would have been tough cases for us. So, all right, iodinated contrast. You can use alternative contrast agents, of course, like air or gadolinium. So here we are injecting a tibio-talar joint and using air to confirm our location before putting the steroid in. Gas can be hard to see on fluoro images, so it can be helpful to take a full exposure and just confirm that intra-articular position. Gadolinium, of course, is also radiodense, totally viable alternative. If you're doing an injection for an MR arthrogram, obviously you don't want to put a bunch of gas in there, and you don't want to put a high concentration of GAD in, because that will mess up your T1 shortening on your MR. So for that, of course, you should just use direct visualization with ultrasound. So pretty straightforward. Allergies to antiseptics. So we kind of have two big antiseptics everyone uses. So chlorhexidine. There's a very low risk of a true anaphylactic reaction if you're just exposing the skin. It's a little higher if you expose mucous membranes or parentally. I will say that chlorhexidine, if you're working near or around mucous membranes or soft tissue ulcer or surgical wound or something like that, It's more likely than providing iodine to be irritating and painful to those tissues than providing iodine. So I would recommend using this, which is a little more inert if you're working around those kind of sensitive tissues. When reactions do occur, they tend to be more these IgE mediated localized reactions, so basically hives. Just important to note that that's prone to hypersensitization, so you can have a mild reaction, and then with further exposures, a much more severe reaction. Most providine iodine reactions are also misclassified and are actually irritant. And then just kind of note, if they have an intravenous contrast allergy, that's not necessarily a strong contraindication for using this antiseptic. All right, adhesive allergies, very common. Most of these are also irritant contact dermatitis rather than a true allergic contact dermatitis. However, it's very hard to differentiate those without patch testing. Generally speaking, most of our procedures, the patients aren't wearing dressings for that long, and most of them will tolerate them pretty well, even if they have a listed allergy. The other thing I always tell trainees is if you have a listed allergy to adhesive, that usually means that you have some experience with medical procedures. And so these patients often just know like what they can handle, what they react to. So just ask them. If they don't know, I'll give them kind of a grab bag of a bunch of different dressings and let them figure it out for themselves, what works for them. And that way they have that knowledge for the future. Again, because these are usually irritant type reactions, they resolve quickly after removal. All right, managing barriers to moderate sedation. So here's kind of our list, our guidelines for anesthesia consult when you're thinking about moderate sedation. So ASA physical status classification of 3 or greater. I think this is the one we tend to skirt around the most as, you know, a metastatic cancer patient. Most people would consider ASA 3, and we're certainly not getting anesthesia on board for all of those patients. So this really is, you know, it's a guideline for a clinical judgment. So other things to think about: high Mallampati score, history of difficult airway, history of complications from prior sedation, obviously a big one. Hemodynamic instability, usually going to be in your inpatient cases. And that's something that can come up, is not always apparent on chart review, is this history of chronic high dose opioid or benzodiazepine use, whether that's prescribed or illicit. So this would also include our methadone and Suboxone therapy patients. So the issue is you're very unlikely to be able to get adequate pain control with moderate sedation in these patients. And so typically you're going to be left with the choice of trying it without sedation versus getting anesthesia on board. Also important to note if they've had a recent reversal with of opioids with naltrexone. All right, NPO status, obviously recommended for moderate sedation. If they're not NPO, or let's say they're semi-NPO, like to say, just discuss with them. You can talk about some alternative pain control strategies like using tramadol or some other central analgesic, doing it without moderate sedation, and that can include giving some longer acting IV pain medicines before or after a procedure, and then just using local anesthetic. GLP-1 receptor agonists, these have obviously skyrocketed in use over the past few years. And the issue with these is that they can cause delayed gastric emptying, which has a potential to increase your aspiration risk with moderate sedation. So there are new multi-society guidelines from last year, and basically those recommend continued use in low-risk patients. In high-risk patients, and what makes someone high risk is if they're on a high dose, if they've recently increased their dose, if they're on long-acting meds, which most of these patients are on the weekly sub-Q injections, GI symptoms or other conditions that can cause delayed gastric emptying. So for those patients, it's recommended that they get 24 hours of clear liquid diet in addition to the normal NPO, as well as a shared decision-making about whether to discontinue those meds. And typically it's just going to be a single dose that's discontinued and a discussion of bridging meds. I think the reality is for us at our institution, and I think most places, it's really difficult to make an accurate assessment of whether these patients are low risk or high risk before they come in for their procedure. So we have this kind of compromise guideline in place where generally the meds are continued, but we recommend a 24-hour clear liquid diet for all of these patients. All right, approach to consent. This could be an entire talk on its own, so I'm not going to go through all of this in detail. The one thing I do like to harp on with this is this time pressure idea. So if you're behind on your procedural schedule, this is not the time to make it up. The consent process is not where you should rush through. You need to allow time for patient reflection, addressing concerns. You know, you need to realize that they often have no idea what you're about to do or why they're there. And sometimes they're there for things like a biopsy to confirm a cancer diagnosis, and that can really be a traumatic experience and something they're going to remember for a long time. So the consent process, it's your first impression. It may be the only impression that the patient actually remembers. And so it's just really important to take your time with it, answer all their questions. And going through a good informed consent is going to improve your rapport with the patient. And it's also going to improve understanding in the event that a complication does occur, and that can actually decrease your medical legal risk if a complication happens. So it's to your own benefit to really take your time and do a good job with these. Right, room setup. Again, a lot of this is very kind of intuitive, straightforward stuff. You want everything where you can reach it, and you want to minimize radiation dose to everybody. One thing I'd like to focus or kind of emphasize for our younger trainees is this ergonomics idea. I think when you're young, I certainly this way is you don't really care if you're like hunched over for an entire procedure, or you're craning your neck 90 degrees to look at a monitor. But older you is going to pay for that, and you should really try to establish good habits early on. So do everything you can to maximize your own comfort, ergonomics, especially if you're going to be in a longer case or wearing heavy lead and that kind of thing. So, all right, equipment selection. Again, this is a huge topic. There's a ton of devices out there. I'll skip over most of this in the interest of time. Essentially, most of this ends up coming down to a lot to personal preference and experience. There are some more objective general considerations about certain devices like these power assisted drill devices. Happy to come back to this if anyone has any questions about any of this. All right, planning the approach. So a quick case to run through. This is a guy with esophageal adenocarcinoma. He has multiple lesions on his PET CT. And this is really a dealer's choice biopsy request. So you can go after anything. They just want some tissue to make a diagnosis. So the question is, what's the best target here? And if we kind of look through these one at a time, we start here at A, the sternum, the manubrium. This is a tiny lesion. It's sub-centimeter. It's right at the posterior cortex. And right behind that, of course, we have these important vascular structures. So maybe not optimal. Clavicle, it's decent-sized lesion, minimal risk profile. The sacrum, also good-sized lesion. It's not quite as accessible unless you do something like go through the SI joint. And then, of course, you do have to worry about epidural bleed when you're working around the sacral foramen or canal. And then lastly, there's this gluteal soft tissue lesion. So this was CT occult. It's decent sized, and it's a reasonable thing to go after. But I think the fact that you can't see it on CT, you don't really know if you're going to be able to see it on ultrasound until the patient shows up for their biopsy. And it's also adjacent to these major arteries here. May make these a little less desirable. So I think of all these, of course, there's some subjectivity, but the clavicle is probably the most optimal thing to go after, which is what we did in converting metastatic disease. So whenever you're looking at multiple lesions, you want to target a lesion that's going to optimize the associated risks with the greatest diagnostic yield. Now, how do you determine diagnostic yield? It's difficult, honestly. It's multifactorial. It's often unpredictable. I do think it's something you get better at as you do more and more biopsies. But there are some objective positive predictors, which include larger lesions, taking more cores, at least 3, using larger gauge devices, and having path present during the procedure. Things that decrease your diagnostic yield are sclerotic bone lesions and heterogeneous soft tissue lesions. I would argue that technical difficulty, how difficult something is really a secondary consideration for target selection. So imagine a case where you have a very high yield looking promising rib lesion and then a kind of equivocal pelvic lesion that's much easier to access. So you can go 2 routes on this, right? You can go for that easier pelvic lesion, but you know that if that comes back negative or equivocal, you're probably going to have to come back and do that rib biopsy anyways, or you can just go straight to the higher yield rib lesion. And honestly, either of those are totally fine paths to take. I think which one you prefer really depends on kind of how comfortable you are with the technical aspects of doing the more challenging biopsy. So, all right, intralesional targeting. So one of the reasons that large heterogeneous soft tissue lesions are associated with lower yield is that not all tissue is the same, right? You want to target parts of the lesion that reflect the viable active tumor, and are the highest grade of the lesion. So that's reflected on imaging as more contrast enhancement, more flow on color Doppler, more activity on nuclear medicine studies. You want to avoid necrotic or liquefactive components of a mass. However, if you look on this case, for example, you see this very enhancing nodular part of the mass, centrally non-enhancing and necrotic. And the idea is the edge or margin of these areas are often a leading edge of a viable tumor where it's rapidly growing, and then the central part is necrosing as it outgrows its vascular supply. When in doubt, just widely sample a lesion. So take a bunch of cores from a bunch of different looking parts of the lesion and hope for the best. So as I said, in this example, very large thigh mass, fat containing, and you can see it's massive, it's impossible to miss, but if you target this area, this just looks like kind of mature adipocyte tissue. You really want to go for this nodular enhancing part and avoid this necrotic part. Fortunately, if you look closely, you can see these little foci of low intensity signal, and that reflects these areas of calcification on our CT. So this is a really nice marker for us to make sure we're kind of going straight where that most avid enhancement is. And this is indeed a dedifferentiated liposarcoma. Speaking of sarcoma, approach planning in sarcoma is also important due to the concern for tract seeding and the need to take into account limb-sparing surgical techniques. The ideal is if you have a sarcoma surgeon, orthopedic oncologist to talk to and just kind of discuss what's the best approach and come to an agreement. Another tumor that you should worry about tract seeding is desmoid fibromatosis. I would argue that for any soft tissue tumor where there's a concern for tract seeding, you should use a coaxial approach. And the idea with that is you can take your introducer needle, get it right up to the edge of the lesion, and then sample multiple times coaxially, rather than having to make numerous smaller tracks every time for every pass that you make within that lesion. So for sarcomas, if it's in the bone, there are, and you don't have a surgeon to talk to, there are anatomically based guidelines to provide recommended approaches. These are very detailed. They tell you exactly where to go and the justifications for that. So it's really helpful. Soft tissue lesion guidelines are a little bit less established, but generally utilize a compartment-based approach. And in general, kind of a common sense approach of avoiding multiple compartments, staying away from bursa, staying away from joint spaces, neurovascular structures, as well as certain important bony landmarks. A couple examples. This is a 27-year-old man. He has this elbow mass. It's PD bright and heterogeneous next to the radial head here. So this is sitting within what's called the mobile wad compartment of the proximal forearm. And when we decided to biopsy, we decided to take this lateral to medial approach. And the idea here is we're only going through a single muscle here, one of these, extensor carpi radialis muscles. And that muscle is already involved in the mass. And we're also giving a nice wide berth to this radial neurovascular bundle. So here's our biopsy picture. Again, you can see just going through that single muscle, able to sample that tissue and staying away from any important structures. So this turned out to be a synovial sarcoma. Another example of kind of taking limb-sparing considerations into account here. So this is a patient with an aggressive glenoid mass. It has these vascular flow voids inside it, so a very hypervascular mass with sarcoma in the differential. Now, in thinking about limb-sparing surgery in this location, the approach is going to be this anterior deltopectoral incision, basically along the medial margin of the deltoid here. So with that in mind, we decided to take a transcoracoid approach to get to this mass along the medial margin of the deltoid. The idea with that is that if tract seeding does occur, it's going to occur exactly where they're making their incision and is going to be readily resectable. And this was a successful biopsy. However, it did have some persistent slow hemorrhage from our biopsy needle, and we were able to control that with gel foam, which is this hypodense stuff you're seeing here, and I'll talk a little bit more about that later. All right, patient positioning. So important to talk with the patient during consent, make sure that they're going to tolerate the position that you want them to be in and for the time that it's going to take. The other fun thing with musculoskeletal lesions is that you can really change the trajectory for a lot of these lesions, particularly on CT, especially around the shoulder and the hip. And that can really help you in what would otherwise be fairly difficult quick cases. So here's an example. We have a lesion in the scapular spine. This is on our just diagnostic CT. So the patient is supine with their arm down by their side. And this reflects the axial plane on that scan. When we brought them in to do the actual biopsy, though, we had them prone and we had them stick their arm over their head and adduct, so basically in a Superman kind of position. And you can see how much that changes the apparent axial angle, right? It's almost 90 degrees different. And that gives us a really nice flat landing spot on the scapular spine and also a longer throw through that lesion, which improves our yield. All right, patient positioning, you can also move sensitive structures dependently away. So patient with breast cancer and a single rib lesion here. Obviously this breast implant, which is almost covering the rib there is a little concerning, but when you turn her over on her side, it moves away several centimeters and gives you a much safer window to get into the rib without risking damaging that implant. Another example here, this anterior acetabular lesion, and we're pretty jailed out anteriorly by our femoral neurovascular bundle, but also this very large bowel-containing inguinal hernia sitting here too. When we did the procedure, though, we tilted them up on the side, and actually the weight of this bowel-containing hernia actually kind of helped pull everything away, including the femoral nerve right here, and it gave us a really safe trajectory to go deep to all those things and get into this lesion. All right, having path present, pros and cons. So there are a lot of pros to having path present. It's associated with higher yield, as I talked about. It can increase your confidence, especially if you're doing a really difficult case, something that's small, something that's occult, something that's hard to reach, or repeat biopsy, thing like that. They do all the specimen handling for you, which is really nice. Can't screw that up. And it can, yeah, to just increase your confidence. But I think there are some cons that people don't always think about. They are going to increase your case and sedation time. You have to wait for them to look at everything. Bone pathology in particular is quite difficult, and their helpfulness can depend on the expertise of whoever's there. The other issue with bone cores, especially sclerotic lesions, is what you're doing is you're taking your cores and basically wiping them on the slides and seeing what cells touch off. And for bone, especially sclerotic bone, the cells often just don't touch off. And it doesn't mean they're not in there, they just can't see them on their slides. So frequently, you have path there and they just kind of say, nothing's touching off. Do you think you're in a lesion? And it doesn't really change anything about your technique or how many cores you take. And so it just kind of adds time to the procedure. So what I would argue is what we do here is cases that are technically straightforward with a known or highly suspected diagnosis. So say confirming widespread metastatic disease in someone with a known primary, you can probably excuse me, you can probably forego pathology in those cases without really impacting your yield. All right, pain management, to wheel or not to wheel. I think everybody has an opinion on this. What we do know for sure about local anesthetic is that using excessive volume and injecting too quickly increases pain. So don't do that. Don't dump a bunch of Lido in places where it's not going to be helpful, and don't inject too fast. The argument against skin wheels is this. There's kind of twofold. So one, if you are injecting perpendicular to the skin, you're going to activate fewer nociceptors than if you go at an oblique angle like this. The other thing is that if you're doing a immediate subdermal injection, you're still going to numb up these nerves. Whereas if you do this in the dermis is less compliant and more densely innervated, and so it's going to activate more nerves and be more painful. So I think foregoing a skin wheel is a reasonable thing to do for a lot of, especially simple procedures. Obviously, if you need to make an incision, you need a wheel. And the other nice thing about a wheel is if you think you're going to have to make little adjustments to your skin entry site, it's nice to already have that wheel in place. So again, personal preference, I think. Nerve blocks. So this is a useful technique for what would possibly be painful procedures. So particularly new nerve tumor biopsy, like peripheral nerve sheath tumors. So most tumors, you put a needle in, they don't feel anything, but there are some tumors that can be painful, particularly peripheral nerve sheaths. So one technique here is to do a proximal block of the nerve. The technique here is you want to visualize your nerve in short axis on ultrasound, and you're just trying to infiltrate that local anesthetic circumferentially all the way around that nerve. And you're going around this external epineurium of that nerve. So obviously very important that you don't want to damage the nerve itself. And in order to get this circumferential fluid, you're probably going to have to reposition your needle at least once. So kind of top and bottom or front and behind. So here's a case of a tibial nerve block at the medial malleolus. You can see we've already infiltrated a bunch of fluid or local anesthetic superficially, reposition our needle deep, and getting a nice circumferential fluid. And that nerve block allows us to do what would otherwise have been a very painful procedure, which was to inject and fenestrate this very inflamed plantar fascia. Periosteal numbing. So this is the other part of bone procedures that can be very painful. The periosteum is very densely innervated, and it's very tightly affixed to the underlying cortex by these Sharpie's fibers. And the problem is that it makes it difficult to infiltrate a lot of local anesthetic into the periosteum or cortex. So there's honestly not a ton of evidence out there for any of these things that people do, but they're very commonly done. So I'll talk about them. So one is scoring the cortex with a beveled needle tip. The idea is that you're just kind of violating the periosteum and hopefully getting more infiltration in there. Most people also infiltrate in a circular fashion around your skin site. So you kind of score here and then tap around and inject more lidocaine. You can use longer acting local anesthetics like bupivacaine or a 1-to-1 mix of lido and ropi. And this is probably the area where you want to concentrate a higher volume of your local anesthetic. So in most soft tissues, a little lido goes a long way, but not so much at the periosteum. I would say that if you're doing multiple procedures, multiple injections, anything like that, especially in a smaller patient, a lower weight patient, you do need to start thinking about lidocaine toxicity levels. So if you're hitting kind of 15, 20 plus cc's of lidocaine, especially if you're also using other longer acting local anesthetics, in a smaller patient, because it's weight-based toxicity, that's when you really need to kind of step back and be a little more conservative and start thinking about the possibility of that. All right, perilesional numbing, fairly straightforward idea. For most of our lesions, we just kind of numb the capsule or the side of it that we're going to enter, take our samples, and be done. But for small lesions, particularly if you're using one of these soft tissue devices that has this dead space here where you're not sampling, it's easy to go through and through the lesion. And if you get into this unanesthetized soft tissue, that's going to be painful every time that needle goes there. So just make sure you numb both sides, similar to our nerve block, right? So you just reposition the needle and numb the entire course of your expected biopsy of the needle. All right, intramedullary bone pain. So this is the other cause of bone pain. And this really relates to a coaxial access to bone. So changes in intramedullary pressure cause pain by activating both these A delta and C fibers. So it can be sharp localized or that dull deep kind of bone pain. And this pain can't be anesthetized with local anesthetic. It can only be mitigated by a nerve block or, of course, general anesthesia. So when you're using a coaxial device and you're in bone, the main thing that causes these changes in intramedullary pressure is how quickly you remove or insert your needle or coaxial device. And so the faster you go in, the higher the change in pressure. And also when you're moving or inserting quickly, it actually worsens things because you cause a Bernoulli effect that actually pulls additional air molecules along. The other thing to think about is the length of your coaxial device. So if you have a 5 centimeter versus a 15 centimeter introducer needle, and you put your stylet in at the same speed, then it's going to cause roughly 3 times higher change in intramedullary pressure. And some patients don't feel this at all. Like it doesn't bother them. They feel absolutely nothing. But some patients are exquisitely tender to this type of pain, and it's really hard to predict who's who. So if you're doing a procedure, you're noticing the person's wincing or moaning every time you pull your needle out or put it in, just go slow, because all you can do is try to minimize this change. Go slow, and that should make them much more comfortable. All right, creating a buffer. So gas or sterile normal saline can be used to displace sensitive structures and create a buffer space and kind of increase your safety window for your biopsy tract or other needle tract. So here's a case of a patient. She had this left distal iliopsoas mass concerning for possible sarcoma. So we talked with our sarcoma surgeons, and they said, we want your approach to be medial to both sartorius and rectus femoris, which of course is going to place us right into the femoral nerve here. I do sometimes think the trajectories they give us are just done to kind of mess with us or make our lives a little more challenging. But at any rate, obviously a little bit of a scary trajectory, but we were able to accomplish this by first placing a smaller gauge spinal needle, advancing it very carefully to that area, and using stereonormal saline to hydrodissect. And what that does is it just pushes those nerves aside. You can see here at this level, we have two divisions, an anterior and posterior division. And so basically we were able to kind of split the difference between them and use saline to push them aside. That gave us a wider window to put our larger biopsy device through. Of course, you want to use a coaxial system here, not only because of sarcoma, but you only want to thread this scary trajectory once, and got samples. And the patient did well. They had no complications, and this turned out to be just an intramuscular myxoma. All right, transosseous or long osseous approaches. These are sometimes counterintuitive. They may look like you're making your life harder than it needs to be, but they can be helpful in some cases. So here's an example. This patient has prostate cancer and this kind of indeterminate lucent lesion in the iliac bone. And you may think like, why don't I just cut through the glutes here and just directly sample? It seems pretty easy. The problem is right here, again, the superior gluteal arteries are sitting right there. It's right over the lesion. It's going to be impossible to see them on your CT fluoro images. And if you damage those, you can cause really a severe bleeding complication. So instead, we opted for this much longer route through bone. And this turned out to be benign. Oh, yeah, there you go. A transosseous approach. So here's an example, an incidental lesion at the right S2 nerve root here, which was asked to be biopsied. And to get to this, we did this transosseous approach through the sacrum. And the benefit of going through bone, especially a long course of bone, is that your trajectory is completely fixed. So if you actually really want a high degree of precision, it's quite nice. In this case, you're only going to be able to biopsy exactly where this needle is. You're not going to be able to move it around and hit something that you don't want to hit. So that minimizes the risk to the S2 nerve. The downside, of course, is that if you go off target, you kind of got to pull back and start all over. But this turned out to be a benign schwannoma. Right, gaining purchase on slippery structures. So ribs, I think, infamously difficult to access. Other small curved bones like clavicles can also be difficult. The way I teach this is that regardless of kind of how you approach this, ultimately getting access to bone is a matter of tactile feedback. So particularly for ribs, the imaging is only going to get you to the surface of the bone. So it's going to get your needle where you want it to be. But to get inside that bone, you're going to have to rely on your own tactile feedback to tell you, am I inside the bone? Is the needle starting to feel solid? Or if the needle tip moves or if it slips off, in which case you have to pull back, use your imaging to get back where you want to be and try it again. You can kind of go two routes to get into a rib. You can point perpendicular to the rib, so straight down. The benefit is that gives you a flat surface, at least in one axis. But the downside is, of course, you're pointed straight at the lung and pleura, and it gives you a shorter throw through the bone and through the lesion. You can alternatively go for a more oblique or parallel approach. This is going to be very difficult to access this way because you're not only going to slip above and below the rib, but also down the barrel of the rib as well. But if you get in, it gives you a much longer kind of throw down the axis of the bone. What I usually do is a combination of these two techniques. So I will approach, go through the scan and approach the rib in a much more oblique fashion. Once I get my needle tip where I want it to be, I will crank it up so it's perpendicular and use that advantage to get into the bone. And then once my needle's just a little bit in the bone, I flatten my trajectory back out in order to be able to take a longer sample down the bone. That's pretty successful for me. All right. Couple strategies here for sampling difficult lesions. So on the screen left here, for small sub-centimeter soft tissue or small lytic bone lesions, I have this bridging the gap or sandwich technique. It's very simple. The idea is just that whenever you take a core, you're spanning the entire lesion within that core. So you'll have normal tissue on the end of the core and lesional tissue sandwiched as the white stuff in the Oreo. So just a couple examples here. And the idea is that especially if it's a small friable lesion, if you have that normal tissue in there, it's going to help hold it all in place and keep your core intact. So here's a couple examples, a very small lytic lesion in the left iliac. We took this long device and we're able to take a big core through that entire lesion. Same thing with this ultrasound biopsy. So this small sub-centimeter lesion, you can see our tray here that's actually doing the sampling, spanning the entire lesion. Highly necrotic, liquefactive, or friable lesions. These are often very large aggressive masses, and they can often be the most difficult to sample, and it's because so much of it ends up being this kind of gooey non-viable tissue. So a couple of excuse me, a couple techniques that I found useful in these cases. One is marginal sampling. So as I talked about before, usually the edges of those lesions are going to be the active viable disease, whereas the center is going to be kind of more necrotic stuff. So what I do is I plan a trajectory, for example, this acetabular lesion, where I'm going to really skirt the margin of the lesion. And you can see here, I actually start my sampling here in what looks like relatively normal bone. And the idea is that even if my first couple of cores are just normal bone, as I continue to advance along that tract, I'm going to hit, an interface where I go from normal marrow to disease marrow, and that marrow should be kind of the right edge of the lesion where it's most viable. So that's what you want. The other idea here is this bony backstyle, kind of similar to the sandwich technique. And that's if you have a really friable tissue and you think it keeps falling out of your core, your needle, whenever you're retracting it, you want to end your core on a piece of normal marrow. Or you can even use a little bit of the endosteum of cortex as well. The idea with that is you may have this kind of mushy, friable tissue in here, but you have a much more solid piece of bone sitting at the end of your biopsy needle, and that's going to prevent it from falling out whenever you retract it. So both of those techniques have been very successful for me. All right, modality occult lesions. Just go through this quickly. So this was a patient with CLL. They had this new avid focus of disease that they wanted us to biopsy, but it was completely occult on CT. She did get an MR, and this is the lesion here. And whenever you have a lesion that's going to be occult, you need to use some sort of anatomic landmark in order to target your biopsy. So in this case, we notice this posterior part of the S1 foramen is just posterior to the lesion. And you want to pick something that's very close and that's not going to change when you reposition the patient as well. So in this case, on our CT, there's that same structure highlighted in red. We know the lesion's right anterior, so we're able to get into that, and this confirmed a Richter's transformation to a diffuse large B-cell lymphoma. So ended up being actually an important a tissue sample that really changed her management. Just another example here, 51-year-old, very remote history of hairy cell leukemia, but been in complete remission for almost 20 years, and had this totally incidental lesion at his ischial tuberosity on a hip MR. And you may look at this and say, like, no, that's a big lesion. It's kind of a large target. It's not going to be that hard to hit, even if it is occult. But just keep in mind, when you change modalities, when you change position, it can actually be pretty challenging to be like really confident that you're where you're supposed to be. Luckily, in this case, we notice here the attachment to the sacral tuberous ligament. There was some enthesopathy associated with that, as you can see here on our CT, and that gave us a really nice landmark to make sure we're dead center on that lesion. And this did turn out to be a hairy cell leukemia. All right, dislodging bone specimens. If you've done a lot of bone biopsies, I'm sure you've gotten some stuck. So sclerotic lesions, and especially very densely sclerotic lesions, are very easy to get stuck in the needles. Whenever you're dealing with these, just take small bites, so 2 to 3 millimeters at a time. Take little chunks. If you start taking ½ centimeter or more cores, that's where you're going to start having trouble. If you're having trouble getting out, a couple troubleshooting techniques here. So you can get a small sterile mallet and just hammer it out. If you do that, definitely you want to put your needle tip in like a plastic tube or something that's going to catch the core so it doesn't go flying across the room, because then you're going to be like crawling around looking for it. I'm not speaking from experience, obviously. The other option here is to heat the end of the needle, and you can use actually a Bobby even, or just like a hair dryer. That heat's going to expand the metal and allow you to dislodge the core without damaging it. All right, transport media, specimen handling. Very important to have good knowledge of this, because you can, have to redo a procedure if you mess up the specimen handling. So the goal here, preserve cellular composition, tissue architecture until Path can take a look at it. And of course, formalin's really a workhorse. That's what we use for most things. It's cheap, it's widely available. It's good for most things. RPMI is a different type of media that was really developed mostly for lymphoma or myeloma cases. Its downsides are it's more expensive. It has to be stored frozen, so you got to find it and thaw it out. And I would just talk with your pathology department and ask them if they prefer suspected lymphoma to be sent in RPMI, in sterile normal saline, or in formalin. My understanding is that you can salvage lymphoma from formalin, but it can depend on how long it's been sitting in it and things like that. So then saline, mostly going to be used for infection, and ethanol, alcohol, specifically ethanol. This is used for crystal analysis. So if you're doing a gout or CPPD case, you need to use alcohol. And that's because the crystals are water soluble, so they just dissolve in saline, and the formalin will degrade them. All right. After the procedure, a few complications to think about. So most of the procedures we do outside the spine are considered kind of low bleeding risk by SIR guidelines. And that's because most of them are superficial structures and you can get hemostasis with just manual compression in most cases. If it's a hypervascular lesion, vascular invasion, or you have a loss of barrier to a large potential space, that can kind of bump things up into a higher risk category. In the event of bleeding from a bone biopsy site, one thing I'd recommend is just keep the introducer needle in place, right? Don't pull it out because that's going to often make it much harder to control the bleeding and give you a larger hematoma ultimately. So having the introducer needle in place lets you put the stylet in. That produces a tamponade effect. It's going to hopefully cause things to clot up, and you can just kind of slowly retract the needle, keep checking by pulling your stylet out, and hopefully getting control of the bleed. If it's a really fast or persistent bleed, what we've done is, and multiple times, is instill gel foam into the biopsy tract. So you can go get your gel foam kit, prepare it, and then just slowly instill it along your tract. It's going to show up as this hypodense material, and slowly, same thing, slowly retract the needle, leave the stylet in. And that's something that we've had a lot of successful for what were very brisk and kind of scary bleeds from bones. Pneumothorax, of course, can happen when you're doing rib or other adjacent biopsies. Just anytime you're working here and you think you might have caused a pneumothorax, just stop. You can do an intraprocedural, post-procedural CT and continue if needed. The main thing, though, is that pleura are very sensitive, right? And you're not numbing them. So anytime you do what I call testing the integrity of the pleura, the patient's going to yelp. They're gonna gasp. They're gonna maybe take a swing at you, but they're gonna let you know that your needle's in a bad spot. So that's very useful for when you're again working around these areas. If you do happen to cause a pneumothorax, obviously you want to monitor them. If they're asymptomatic, you should get radiographs at 1 and 3 hours post procedure. Make sure that pneumothorax isn't enlarging, and at that point they can probably be discharged home with close return precautions. Symptomatic or enlarging pneumothorax, you're heading towards a chest tube. So that's something you feel comfortable doing yourself at our institution. Those complications would be managed by IR if they ever happened. But so, and then lastly, pain. So significant post-procedural pain after most of our procedures is not really expected. And generally pain can be managed with just oral analgesics and ice packs. It is important, especially if somebody has pain before the start of the procedure, to just talk with them and try to kind of manage their expectations for post-procedural pain relief. And the other thing that's good to know is the pre-procedural, if someone is very anxious before they start a procedure, they are likely to experience a higher intensity of pain both during and after the procedure. So it can be helpful in those patients after you've done your consent. Just give them an anxiolytic, and that can really help calm them down and make the procedure easier both for you and for them. If you have disproportionate pain after procedure, you need to start thinking about other complications like fracture, nerve injury, or frequently hematoma pushing on something. Rarely, if the pain is really severe and new and related to your procedure, you may need to go back and do some other procedure to help address that. Obviously, the best thing to do is to do those procedures anticipatory, whether that's a nerve block or some sort of epidural injection. So here's a case, 57-year-old with this facet cyst. We attempted to rupture it under CT, and you can see we got some contrast into it, but unfortunately weren't able to rupture it. And the patient complained of this new radicular pain. And so we ended up doing an translaminar or interlaminar epidural steroid injection here, as well as, I believe, directly penetrating the cyst as well. And that relieved the pain. So some people would actually do this, some sort of epidural injection, just anticipatory prior to even attempting a cyst rupture. All right, lastly, I'll go through this quickly, some CT specific considerations. So when you're using CT fluoro, you have a bunch of parameters you can change. I'm not going to go into too much detail, but just remember the goal isn't to make a beautiful diagnostic picture. It's to get the job done safely with as low a dose as possible. So in general, what to adjust, I'd say if you're having trouble seeing a target, start with adjusting your current. If it's really more of a penetration issue because the patient's large or they have metal or something like that, probably work on your voltage. Slice thickness can obviously be helpful, especially for resolving really small structures or lesions. And then optimizing your field of view is just good for a bunch of reasons, and you should always do it in every case. All right, using the integrated laser. So most CT fluoro machines have these laser grids, and the central laser corresponds to the axial plane of the scanner. So this is a very common trick I think most people know about. If you have your needle and this laser is intersecting both the skin entry site and the hub, you know that this needle is in exactly the axial plane. So it's a really helpful kind of marker to kind of correct the needle position or adjust it whenever you're advancing it. Right. Lastly, gantry tilt. This is very handy in a lot of cases. And, without giving too many specifics, basically, this allows you to take a kind of an oblique approach to a target, but still maintain your needle within a single slice, right? And that's a lot easier than trying to take an oblique approach through multiple slices just to track your needle position. And then lastly, minimizing streak artifact, just this little tip. If you are using a coaxial device and you're getting all this streak artifact and it's making it hard to see something that you need to see, just pull the stylet out and that streak artifact will largely go away. So that's my last little bit. So that's all I've got. They did go over. Yeah, happy to answer any questions anyone has.
Excellent, Hank. That was beautiful. Folks, you can use the QA section with any questions. Hank, I enjoyed your talk a lot, and I realized, you talk from experience, shooting the core across the room. That happened to me, yes. And one of my fellows, we were pushing it out, and we had to go find it in a corner of the room. But some questions for you. What is your preferred anxiolytic agent or drug for patients who are anxious before a procedure? What would you recommend?
I think typically we just kind of default to using Versed. I would say, especially if we're doing moderate sedation anyways, kind of just giving one round. I think diazepam sometimes has, I've had cases of using that as well. It's just like usually in most of these cases they have the Versed like there with midazolam there, and it's already there and ready to go, so just easiest to use that.
Excellent. Very good. I want to remind everyone that there is a survey in the chat now. If you can fill that out, that's going to help us for future talks so that we know what you guys like and what you want to see. So please do take time to fill out the survey. Now, we have two talks already. One is about arthrograms, spinal injections, and bone biopsies. How long do you suggest the patients to rest?
Okay. So are you talking, I guess it depends. Are you talking about just your sedation recovery time, or are you talking about like activity restrictions
I think
after?
it's activity. That's how I understand the question.
Yeah. So in general, for arthrograms, we don't want them to move around before they get to the MR or CT or wherever they're going. But we generally don't give any specific restrictions. I usually tell people there's some numbing medicine on board. It's going to be, it's going to last for 6 to 8 hours. So you may want to wait a little bit, just see how you're doing. And I tell people just listen to your body. Don't do anything too crazy, but honestly, we don't have any specific activity restrictions. Similarly with bone biopsies, I think the risk of actually causing a fracture or something after a bone biopsy due to activity is very low. I've never seen it happen. And in general, people do recover quite quickly from bone biopsy, unless they have some bleeding and hematoma, in which case they may have some soreness along your needle tract, which is usually pretty mild and resolves within a couple days. So same thing. I just tell them, listen to your body. If you're feeling good, go for it.
Excellent.
Oh yeah, and sorry. Lastly, for
Yeah.
spinal injections or other steroid injections, there's one little caveat to that, which is sometimes people feel so good they get so much relief from their steroid injection that they decide I'm going to go run my half marathon now, or climb a 14,000 foot mountain or something. And if somebody really is overactive with whatever joint or structure was injected, they can actually work through that steroid quickly and basically reduce the longevity of its effect. So sometimes people will get great relief, but then they are overactive and they may lose that therapeutic benefit within days or weeks instead of the months that we're going for. So that's the one caveat is like if you feel great, still just kind of ease into it.
And for steroid injections, we do a lot of psoas and biceps injections, and I tell them no psoas stretches for a whole week, or because they can tear the tendon too. So that's another caveat. So at least 3 days, but better so a week. That's my recommendation.
Yeah, definitely. For soft tissue injections, definitely.
Yeah, exactly. Yeah. Now, another question in the QA, do you always require marginal sampling for soft tissue lesions?
That's a great question. I think with soft tissue lesions, you really just want to make sure you have a great idea of where the optimal tissue is, right? So if you don't have adequate, if it's a really large lesion and you don't have adequate imaging like an MR or some other or nuke study or something that's going to show you which part of that lesion is most active, I think it's better to defer the biopsy and get that imaging that's going to give you the answer of exactly where you should be putting your needle. The alternative, if that's not really an option, would just be to take a bunch of samples from everywhere, essentially. Like so, go to the middle, go to the margins, probably focus on the margins because that's probably where things are going to be the most active. But I think it's better to have as much information as you need in order to maximize success rather than putting patient through multiple biopsies or the other thing that can happen is if you have a sampling issue is they may think that this lesion is lower grade than it actually is, less aggressive than it actually is, and that can cause some significant problems for the patient down the road. It may change their surgical technique if it's a sarcoma or something they're going to resect and things like that. So for all those reasons, I think a lot of, and again, this kind of goes back to a lot of the nuance of what makes you good at procedures. And I think it's not adequate to just kind of stick your needle in and get tissue and say you're done, right? So you need to know which things are going to be the best for the patient, that are going to improve your yield. And I think a big part of that is also whenever you have an unsuccessful biopsy or something that is unexpected, really go back and look at those, take a close look, analyze them, and try to figure out, is this just bad luck or is this something I could have done differently before the procedure?
Sounds good. Very good. We have another question that just popped up about if you would use MR perfusion for planning for image biopsies, or do you rely on contrast enhanced MR and or ultrasound for planning? You rely on
Yeah,
everything, right? Whatever you can get.
yeah, exactly. Totally. I would say here we don't do a lot of MR perfusion imaging, so the vast majority of what we're doing are just your typical post contrast MR or ultrasound, and I think that's adequate for most cases. I think there are some lesions where it may be helpful to have perfusional imaging or like some sort of dynamic contrast imaging. So the big one that comes to mind for me is like peripheral nerve sheath tumors, especially in like NF1 patients. So those are often, whether they're benign or malignant, they're going to avidly enhance, and having some more advanced imaging and information around that, including things like diffusion weighted imaging, is going to be helpful for target selection in those cases, as well as just differentiating which ones are concerning, which ones aren't.
And I'm sure you guys have PET CTs before biopsies quite often. I find PET CTs quite helpful to target the most active portion of the sarcoma. Excellent. I have one more questions myself. What kind of, I know you don't want to talk about brands, but what is your preferred needle for a rib biopsy? A rib lesion that is not expanded, not expanding the bone. Is it bone opti? Which one would you use? What is your preferred one?
So I usually use one of the powered devices. But I don't use the drill to get into the bone. I kind of just have it there in case. But I like the kits around either your oh sorry, uh,
No.
there's a few clones out there, right? There's BD Trek, and then
Yeah, on control.
your classic well, I'm blanking, the orange
On control. On
yeah,
control.
on control,
Yeah.
yeah. I think Striker's actually coming out with another system
Yeah.
next year, I think. The Yeah, so I just like those kits. I like the kind of different options in there. And I also like the coaxial. I generally prefer using coaxial devices, which I know Bonoff you can use actually as well. It's probably a bit of overkill, honestly, because I end up kind of hand cranking in there anyways. But yeah, so bone opties, I definitely used those before, and they're very straightforward, they're very simple, and they get the job done most of the time. But for when things get a little bit more challenging or you need to troubleshoot a little bit, I kind of like having the larger kits and more
Excellent.
options available.
Thank you.
Mhm.
And if I may add something, maybe this is more UCLA, but we for consent process, we have to use interpreters whenever needed. I'm certified to consent in Persian, my mother tongue, but before I was certified, I was not allowed to do it. So so it's very, very strict, and we realized if you use their children or relatives for interpretation, or even some layperson, they may not know the proper terms, and there may be misunderstandings. So make sure you guys that you have good interpretation, and when in doubt, and if you're not very strong in that language, do use an official one. They're usually on the phone, and it's very easy. So
Mhm. Absolutely, totally
oh,
agree.
yeah. Hank, thank you very much.
Well,
Everyone, thanks for participating. I hope you enjoyed the talk as much as I did. I thought it was an excellent, it felt like Hank and I have worked together, and he's been in my procedure room all the time. So I love it that you guys do the same thing we do down here. And I'm supposed to tell you guys that we will be looking forward to see you for our next Resident Educational Club webinar, which is post-op elbow or post-op shoulder imaging, presented by Dr. Greg Hall, and that's going to be on October 15th. So thanks everyone, and have a great rest of your evening. See you next time.